The thought of recurrence is also a psychosocial issue for our patients. They're being monitored very closely for 5 years. So there's always that thought in the back of their head, what if the cancer comes back? What's the next steps? What am I going to do next? It's really important that we just have conversations with our patients and their families about where they're at, what we're looking for, and reassure them that we'll be with them during this journey and help them through whatever next steps happen.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Clara Beaver, Manager of Clinical Education and Clinical Nurse Specialist at Karmanos Cancer Institute in Detroit, Michigan, about prostate cancer survivorship considerations. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome back. Thanks so much for joining us again today, Clara.
Good to be back, Jaime.
So we talked about prostate cancer treatment in our previous episode. And so to start things off today, what are some of the common late effects that prostate cancer survivors might experience?
So we talked a little bit about some of the side effects during treatment, but some of the most common late side effects, those urinary, bowel, and sexual dysfunction issues still come up after treatment has ended. So for urinary effects, it can include urgency and frequency, some incontinence, or a weak or slow urine stream that frequently bothers the patient after they've had treatment. Bowel effects can happen, such as constipation, diarrhea, or inflammation of the rectum, which could lead to bleeding or mucus discharge. And then erectile dysfunction is another side effect that prostate patients often deal with and have to work with their physicians on, depending on what they want with that function. And then fatigue, lymphedema, and skin changes could also occur after treatment.
And I think most of our nurses listening will know that these late effects can differ based on the treatment modality that a patient received. Can you talk a little bit about the differences we might see in somebody who received androgen deprivation therapy versus somebody who received maybe a radical prostatectomy?
As you said, the late treatment can affect those late-term effects. So with surgery and radiation, both of those have the long-term effects of the urinary and the sexual dysfunction, which the patients that have prostate cancer frequently complain about. They have urgency, they can't get their stream going, or it's a very weak stream, or, they're unable to have sexual contact with their partners after treatment. So that's a long-term effect with surgery and radiation both. With ADTs, the long-term effects can include heart disease, such as coronary heart disease or acute MIs. They're at an increased risk for those. Diabetes, bone fractures, again, because of the way that the medication works. We've also seen dementia as a late side effect with ADT therapy. And then if you have ADTs in combination with surgery or radiation, that sexual dysfunction can also be increased. So again, it's important that we talk to our patients about the things that might happen to them after they've received treatment.
Let's talk briefly about numbers. What is the average survival rate that we're seeing in prostate cancer? And how does this differ based on maybe some of the nuance of that prostate cancer diagnosis?
So overall survival rate is about 90% for our patients. Again, if we can find it, catch it, take care of it at an early stage, overall survival is about 90%. If the disease is localized, it's 99%. If we can take out the prostate, radiate the prostate, we can do something with that, localized 99% survival rate. For regional, so if there's regional metastasis, about 90%. And if there's distant metastasis, it's about 30% survival. So again, getting our patients in to get their staging done pretty quickly and get them into treatment can differ on how long their survivorship is.
Thank you. So let's talk a little bit about sort of what that sort of survivorship phase of care looks like for patients who have been diagnosed, perhaps completed their treatment, or maybe a long-term maintenance type of treatment. Let's talk a little bit about what tests they will receive, how long they will need to be monitored and sort of follow up, and if there are any warning signs or caution that we can educate survivors about watching for and identifying and reporting as soon as they occur.
Yeah, so most of the patients will be monitored closely for the first 5 years after treatment. And usually it's about every 6 months. And it really depends on what type of treatment they had, if there's any residual disease, what's going on with the patient. But it's typically about every 6 months. They do look at a PSA with every visit. They look at testosterone levels to see how the patient's doing. And then usually a CBC or a CMP is also done during the monitoring visits, just so that the physician can know where they're at, as well as a physical exam and asking the patient if they're having any symptoms. The patients really should be educated to report any new symptoms, including bone pain, unexpected weight loss, and then problems with urination is always asked about as well. Because again, like we said, those late effects can show up a little bit later after treatment happens.
Let's talk a little bit about recurrence. Do we have any statistics to share just about how often we see recurrence in prostate cancer? And are there any strategies that we as oncology nurses should recommend to our patients to help reduce the risk of that?
So prostate cancer recurs in about 20 to 30% of patients within that first 5 years from initial treatment. So that's, again, why they're monitored so closely. There's not a lot of research out there that shows what can reduce risk, but what has been shown to be effective is regular exercise, quitting smoking, and eating a healthy diet. There is thoughts that those could help reduce the risk. And again, it's really important for our patients to understand the importance of having those follow-up visits so that we can catch a recurrence quickly instead of waiting years down the road. Prostate cancer usually is a pretty slow growing disease. So if we can pick it up quickly in those revisits, we can start another treatment for the patient.
Now, we touched on this just very briefly, but let's dig in maybe just a bit. What are some of the common symptoms of true recurrence of their prostate cancer that we as healthcare professionals should educate our patients to be watching for that really are maybe more concerning for recurrence versus late or long-term effects?
The number one thing that they look at is an increasing PSA. The healthcare providers are really watching that PSA, seeing if it's increased. Is it incremental increases? That is usually one of the first signs. But also if a patient reports hematuria that they didn't have in the past, unexplained weight loss, more urinary symptoms different than what they've had, and then bone pain. That's one of the really common side effects related to recurrence.
Now, we've talked a lot about some of the physical side effects that survivors might encounter. Let's broaden that a little bit to also include some of the psychosocial challenges. What type of challenges might prostate cancer survivors face after their treatment is over, especially in terms of psychological or psychosocial challenges, and how can we as oncology nurses help to provide support to them?
A lot of the patients have urinary, bowel, or sexual dysfunction after the treatment. That can really affect their psychosocial and how they're dealing with feeling like they're a man again or feeling like the person they were before, or how they interact with people. Because if you have urinary frequency, you may not be able to keep a job. You may not be able to travel long distances with your family. If you're having issues with constipation or diarrhea, family meals, going out on things may not be as comfortable as they were before. So really, it's important that we talk with our patients. We go over the issues that may happen with them and really be open. The thought of recurrence is also a psychosocial issue for our patients. They're being monitored very closely for 5 years. So there's always that thought in the back of their head. What if the cancer comes back? What's the next steps? What am I going to do next? It's really important that we just have conversations with our patients and their families about where they're at, what we're looking for, and reassure them that we'll be with them during this journey and help them through whatever next steps happen.
That's so important. I definitely agree, of just making sure they understand that we have a plan of what we're looking for or we're going to do. If we find something, here's what we do next. And so sometimes just providing that reassurance of we have a plan and we're ready, that can also help a lot with some of those psychosocial challenges, as you mentioned. Picking up on one of the things you mentioned that I think is important and also sometimes difficult for us as healthcare providers to discuss is acknowledging and addressing some of the changes in sexuality that can happen after treatment, especially when we're talking about prostate cancer. So can you talk a little bit about how we can help support our prostate cancer survivors who maybe are struggling with their sexuality or sexual health after treatment?
Yeah, I think first and foremost, we need to offer support and allow our patients to discuss their concerns. Sexuality is not something many people are comfortable discussing, but we really need to just talk with the patients and let them know that this is normal. It is normal that you may have some sexual dysfunction. It is normal that you may not feel the way that you did before. talk to us about it. Let us know where you're at. Let us know what your goals are, because there's a lot of things that we can do out there. There's medications we can use for impotence. There's devices and implants that are available to help the patient, to support them and give them whatever their goal is for them, for their sexuality. For some men, it may not be to have sex, but it may be that other things, so it's really about talking to the patient, finding out what their goals are and how we can help them get to those goals.
I think that's great advice. And, you bring up a great point that for patients with prostate cancer, we are often sharing their care at some point on some level with urologists. And so understanding if there is this combined team approach to care, who is talking about, ideally, we should all be talking about it. It's only one person's job or the other, but understanding who has talked to patients about certain symptoms or side effects. Is a single team taking sort of lead on helping to address those and make those referrals? I think when it comes to some of these discussions about sexuality or fertility, my own experience is that I always felt unsure because I didn't always have the answers. And so I think it's important for nurses, oncology nurses, to know that your role isn't always to have the answer. It's just to open the conversation and find out what is important, what they are concerned about, what they're struggling with, and then work with your other healthcare providers or other specialists to help make sure that they get referred to the right people to help address the underlying concern. So I think that's really important for oncology nurses to understand and be okay with, as we don't have all the answers, but we can encourage and normalize that conversation so that our patients feel like they can open up to us and share those concerns with us. Let's talk a little bit about the potential for secondary cancers. Do our survivors of prostate cancer, do they have a especially higher risk for developing any sort of secondary cancers?
Yeah, so prostate cancer patients are at high risk for developing small intestine cancer, soft tissue cancers, bladder cancers, thyroid cancers, thymus cancers, melanoma of the skin. And if they received radiation, there is a higher risk of rectal cancer and AML. Again, some of that is based on treatment of what's been going on with the patient, but also some of that is your internal immune system, right, that is turning on those oncogenes after you've been treated with another cancer.
Another topic I think that comes up more frequently now, which is a good thing, especially in our survivorship populations, is this concept of financial toxicity. And while I think it's obvious that that can be a very acute problem if someone's in the midst of surgery and active treatment, but it can linger. And so talk to me a little bit about how, we might see financial toxicity affect our long-term survivors, our prostate cancer survivors who will have to go, whether it's monitoring, testing, maybe they're on treatment for years. How do we see financial toxicity affecting these patients?
Yeah, so financial toxicity, as we know, affects all of our cancer patients. With prostate cancer, usually at a little bit older age while you're going through this, but there's always that worry of recurrence, right? Like, I've just went through some treatment. I've just paid all this money out. What's going to happen in the future? The frequent clinic visits, it could be the transportation back and forth to the clinic visits, the copay for the clinic visits, having insurance or not having insurance to pay for those clinic visits. Again, we're going to monitor them every 6 months for the first 5 years. So that could add to that financial toxicity. With having a bladder urgency or bowel problems and the frequency of clinic visits, the patients may end up having job-related issues that could lead to concerns with financial status. Can they get enough time off from work? Do they have the ability to get the time off from work to deal with those things? And then there's the ongoing management of the longer-term side effects, and then really monitoring the role of the finances with that. What's the out-of-pocket cost? So really, as oncology nurses, we should assess our patients at each visit about their financial status. If they're worried about it, do they have anxiety related to the cost of what's going on with them? And then make appropriate referrals, whether it's a financial counselor, social worker. If they're worried that they're going to lose their insurance, can social work help? So again, looking at those other team members within our organizations to help those patients so they don't feel that financial toxicity as much.
That's so important. And as I was listening to your response, it really, to me, was just highlighting the importance of coordination of care. Most cancers are treated by multiple specialties. So prostate cancer perhaps is not unique in this, but as we've already touched on in this episode, you've got your oncologist, perhaps your radiation oncologist, urologist. Is there a different surgeon that was involved at some point? And so knowing that all of these different providers might be wanting to see the patient at a certain frequency, and are they doing testing? Are we duplicating testing? And so I think that's a great example of how coordination of care can help identify, hopefully mitigate some of that financial toxicity that could occur if those services aren't coordinated well. And so along those same lines, how do you think that we can work together better between the oncologist, the urologist, oncology nurses? How can we work together to help our prostate survivors receive this comprehensive care, information that they need to support them through their survivorship journey?
So I really think providing survivorship care plans are important for these patients, something that can be sent off to everyone else that's caring for that patient. You have your primary care physician, like you said, your urologist, your oncologist, the oncology nurse, and maybe a navigator, and maybe lots of people that are looking into this patient. So really giving that patient a survivor care plan and putting it with their files to include the summary of the treatment received, because most of the time, the patient's not going to remember exactly what they received. So it's good to have a summary of that. A suggested schedule for follow exams and tests. So again, if a primary care provider is not used to dealing with a prostate cancer patient, they have something to go off from. Schedule of other tests that they may need in the future, including screening for other types of cancer. Are they a smoker? Do they need lung screening? Do they need any other screening related to types of cancers? And then a list of possible late or long-term side effects, not only for the patient to understand, but again, primary care providers, if they're going back to their primary care provider, may not know what those are. So if a patient shows up and says all of a sudden, like, I have hematuria, they're not going to know that possibly it's related to what was going on. So having that survivorship care plan really helps. And then in that care plan, we should include suggestions to improve their health. Again, talking about diet, exercise, making sure that they're doing the screening that they need to do. And then, as always, it's really important for us to be able to provide that ongoing support to the patient and the caregivers, including listening to their concerns while they're going through survivorship.
Well, Clara, thank you once again for joining us on another episode to talk in a little bit more depth about prostate cancer and survivorship. As we reach the end of our episode, we like to always run through a series of some quick questions to help summarize some of the important points we've covered today. So to start that off, how do you think healthcare professionals should pause and evaluate maybe their own hidden or their implicit bias that they might hold about prostate cancer survivorship?
Like we've said in most episodes, we really need to understand our potential bias prior to interacting with our patients. We talked a lot today about conversations of sexual dysfunction and sexuality, and it can be often difficult for us to have those conversations with the patient, but it's also can be difficult for the patient to have those conversations with the provider if they have different sexual goals or needs than what they think the normative sexual orientation or goals and needs are. So again, making sure that we can check those biases before we have those conversations with our patients. And it's important to understand any of the biases that we might have when we have conversations with our patients, because again, we don't know what they're going to say when we walk in that room, right? So we need to just make sure that we put those in check before we deal with our patients.
And what do you think are some common misconceptions about prostate cancer survivorship?
A lot of people think that once the treatment is done, the cancer is gone. Again, we talked about recurrence rate in about 20 to 30% of the patients, which is pretty low, but it can still happen. So it's really important to educate our patients about the importance of follow-up care, making sure that they're coming in for their return visits, but also continue their screening for other cancers. Because again, just because they had prostate cancer doesn't mean they're never going to get another cancer. So we just need to make sure that we continue to educate our patients on that.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think a lot of people know about the long-term sexual effects, but what we don't really talk about is the effect that it has on the patient's self-image, how they define themselves, how they define how they look, their body image, their self-image. So again, I think it's really important that we continue to discuss it with patients and make them comfortable when discussing their sexuality and their goals for sexuality, because they may be having these self-image issues after treatment that they're just not telling us about, and that can affect their quality of life.
That's so important. Thank you for bringing that up. What additional training or education do you think oncology nurses need to help stay current on this topic?
As the ever-changing roles of medicine, precision medicine, treatments, we just need to keep on top of what's going on about treatment and really learn what's happening out there so that we're able to support our prostate cancer patients and survivors. So really, it's just a matter of keeping up with what's going on in every day.
And are there any additional resources that you would recommend maybe for patients or even other healthcare professionals who want to learn more?
The American Cancer Society has some great resources for patients, for nurses that don't really know a lot about prostate cancer, really any cancer. And then, as always, ONS has great resources to help many people look at prostate cancer and other cancers.
Well, Clara, thank you once again for joining us for another installment on this series about prostate cancer. Do you have any final comments to share with our listeners today?
I just want to say, oncology nurses can be great supporters to our prostate cancer patients throughout their journey. We just need to be able to be there for them, continue to assess them, and listen to our patients. As we know as oncology nurses, sometimes our patients tell us things that they never talk to their providers about. So we just need to be there and be open and listen to them.
So true and very well said. Well, thank you, Clara, so much for joining us again.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.